The Safe Airway Society, or SAS, is the interprofessional airway society for Australia and New Zealand.
There are three main reasons why SAS have been created, and in 3 words, that's connection, collaboration and patient safety.
The concept of SAS is really the idea of cross-pollination and bringing the expertise from all those different interprofessional groups to promote best airway practice in all the settings that it can occur.
What we want to do is create an environment where safe and effective airway management is delivered to all patients.
To find out more, visit safeairwaysociety.org.
So welcome back to SAS21. This is the third and final part of this morning's session. So I'd like to welcome back Nikki Mills, an ENT surgeon, and Dave Brewster, anaesthetist intensivist, and Chris Groombridge, emergency physician. So finding opportunities to learn and maintain our airway skills, especially those infrequently encountered skills, can be challenging and was even more so during the pandemic. In this session, we're going to explore how we can maximize our learning opportunities and stress the importance of being a lifelong learner in airway management. So some of the problems we've identified as a panel. So there's a low volume of practice for many airway clinicians. A lot of airway management has moved out of anesthesia into areas like emergency medicine, intensive care, pre-hospital medicine, and paramedicine. And a lot of clinicians therefore become occasional airway operators after their initial training. Even anaesthetists can become occasional operators in some skills, and a great example of that is awake tracheal intubation. Also, experienced operators can be confronted with a new skill. So you might be 20 years down and suddenly hyperangulated video laryngoscopy comes along, and it's a skill that you don't have and you haven't had any grounding in. So some of the solutions that we might apply to these problems: we need to really define our scope of practice as clinicians and decide which skills are core to us and which skills are specialized and maybe should be offered to others or be done under supervision by others. Again, this concept of the scaffolded approach to learning, breaking down skills into their component parts, teaching parts of them and building them up until you're competent and confident. And organization and collaboration between departments, between professions. Also setting standards and ensuring that there's a governance process around your training and around your upskilling. A great way of doing that is to embed airway champions or airway leads within departments or within hospitals. So we've got another poll, and hopefully some people will answer this one. I'd really like you to answer this one if you can. So there's 2 ways to do this. You could either scan this QR code, or if you go to the Safe Airway Society website, you'll find a tab there that's SAS21. Go down to Session 1 Resources, and right at the top of that page, you'll find a link through to SurveyMonkey, and you can complete this poll. And the poll is: should all practitioners in your profession be required to undertake regular airway skills, competencies, or currencies? Should all practitioners in your profession be required to undertake regular airway skills, competencies, or currencies? So you'll find that on the SAS website, or scan that QR code. And please give us some answers so that we can show them at the end of this discussion, because it is quite a divisive topic, this. So, David.
Sorry, John, if I can just interrupt, we've actually got the poll from the first one. If you want to go through that, we've found it.
Oh, have you?
Yeah.
Yeah, sure. Why don't that's fine. Why don't we? That was access to team training. So, do you have access to regular interprofessional team training with your usual team? Yes, we've got about 25%, and no, it's about 75%. So that's kind of what I was expecting. Just talking to people in various professions. A lot of training happens in silos within our own profession, doctors on their own, nurses on their own. Getting people together on a regular basis to do interprofessional training is not the standard, and we need to change those bars around. So that's really interesting. We can maybe discuss that a bit later, but for now, let's get back to session 3, which is talking about getting access to training opportunities. So David, you've done some work in this area. You work as an anaesthetist and intensivist, so you get more airway exposure than most of us mere intensivists. But we would all agree, I think, that airway management is a core skill for intensivists and those other disciplines that I mentioned in the intro. So let's imagine, just for the sake of time, that all of these professions, the paramedics, the emergency physicians, the intensivists, all get a really good basic grounding when they're going through their training. Let's say they go and rotate through anesthesia and they get their airway skills cemented at that point. How are they going to maintain those skills as occasional airway operators? How do we maintain those skills throughout our career?
Yeah, thanks, JG. Good question. Just prior to the pandemic, yourself and I and Chris Nixon and a couple others, we had a look at airway competency and the desires of the intensive care specialists across Australia and New Zealand. And I think we ended up with responses from about almost 40% of all practicing clinicians in the specialty across the two countries. And what we found was more than 60% of intensive care specialists in Australia and New Zealand do less than 10 intubations a year. And they supervise more than they perform because of the need for trainees to get experience. We found that they lack confidence even with supraglottic device insertion. They had almost no confidence with awake fibre optics. So there was a significant hole there in airway skills. What we've obviously seen through the pandemic is that they've been on the front line of intubating the sickest COVID patients. Another paper that we put out with some of the other guys who wrote the airway guidelines with us just prior to Christmas, looking at the airway practices during COVID in Australia, we found that more than 60% of the critically ill COVID intubations in the country were done by intensivists. So we're asking them to intubate, the sickest patients at a time in their career where they have a very low volume of practice. And one of the things that they told us was that there was an almost 90% strong push for mandatory airway competency and mandatory airway training within their CPD, very similar, or within their requirements from the college for their ongoing CPD, very similar to what ANZCA introduced a few years ago, where you had to do 2 of the emergency response activities, be it anaphylaxis or CICO training every 3 years to keep your skills up. Talking to a lot of them, and they are time poor, one of the things that intensivists I think would gravitate towards is hands-on training. Running courses, attending courses is excellent, just to sort of give them a refresher every 3 to 5 years on the decision-making processes and those group discussions and simulations that take place. But really what they want to do is pop tubes in real patients. And we set up when I was an anaesthetist at Monash with the evergreen Nick Crimes 6 or 7 years ago, we set up a program with intensivists coming to theatre, which I think Nick has continued, every few months. They come and just do an emergency list with lots of gallbladders and appendixes on it and just pop in, 4, 5, 6 tubes. And I think Nick might have even expanded the program where they bounce between theatres now and just pop in tubes and leave. And I think that although that doesn't give you the airway assessment, decision-making conversation maybe as a huge focus, but it does allow your technical skills to stay current. So, I think that's probably the best strategy for those in large hospitals with departments of anaesthesia to support departments of ICE or intensive care units, to get the consultants on their non-clinical time to get out and actually just get that volume of practice up a little bit higher. Louise was talking about having to do, Louise Ellard earlier, 30 intubations with new equipment such as hyperangulated VL before she felt really proficient or at an expert level. So when you're only doing less than 10 intubations a year and only using VL, even if it becomes the mainstay of your laryngoscopy technique, it's going to take a long time to feel proficient or to stay proficient. So I think, you know, share, rather than operating in silos, which happens a lot, sharing those learning opportunities that are in theatre, getting the consultants in there, I think is the best way to do it, and also getting them to pop in their rescue techniques. Putting in a few LMAs every now and then is actually really good practice for them, because it's something they have to do when, you know, as Chris can probably talk about better than me with his PhD topic, but you know, when they really are stressed and hyper anxious at the time when that first laryngoscopy fails, how do they feel moving to that rescue technique, particularly if it's not a piece of equipment they've used in the last 5 years?
Yeah, I think that anxiety component is really real, and I think that's exemplified by a couple of things, which I've talked to a lot of intensivists about this. The first is that 85% of them want to be mandated to have training, and I think that is really telling. You know, there's a lot of areas, for example, getting intensivists to be current in advanced life support is a challenge, I'm told by the people who organise that within my hospital. But 85% of them seem to want to be mandated to have airway training. And Chris and David and I all run critical care airway courses, which are all approved by the College of Intensive Care Medicine. And I have to say, my experience, consultants are not signing up to those courses. They're almost all trainees. I do get consultants, but not in their numbers. And some of them have said it's because they're anxious about performing in front of trainees, and maybe we should be running some bespoke consultant-only courses, and they might be more willing to come along.
Yeah, I think that's a great point, John. Sorry to cut in, Chris. I think they would.
No, go.
Yeah, I think they would come to consultant-only courses and just tailor the what we teach a little bit to their needs a bit more. I think that would be great.
Yeah. John, that's actually what we do. We have consultant-only courses, and then the registrar courses are actually the rarer events, because when the consultants are all together, they feel much more comfortable talking about their vulnerabilities and their fears of airway management. So that's been really effective for us.
Yeah, right. Okay, good.
We did that with our course as well.
Yeah, so Nikki, I was just going to come on to you. So you run a fantastic bootcamp course, and really that's aimed at trainees, but you're saying specialists also come.
Yeah, so we've run some specifically for consultants who have to cover paediatric airway on call in peripheral centres, and just kind of upskilling and updating them and giving them a bit of coaching of how to do things in a way that's perhaps safer and more efficient. And it's actually been embraced and thought to be really helpful for those consultants. I was quite apprehensive about doing it for a course for consultants, but actually for people who aren't doing paediatric airway stuff all the time, they found it really helpful.
So we talked about access to courses and making bespoke courses for more experienced practitioners. What you were talking about, Brewster, which is something that, you know, requires a high level of organisation, is actually rotating people through operating theatres. Chris, we've heard how Claire, as a pre-hospital physician, has the luxury of time. You know, they have for long shifts where they might not have any calls and they can do their competencies. You're also an emergency physician, and for those emergency physicians who don't do pre-hospital medicine and just do emergency medicine, what's the access like during the working day to kind of training opportunities, and how could they be improved?
Yeah, it's actually quite frustrating because you have to let the trainees do it. So every now and again you can elbow your way in and ask to have a go, but usually it's the trainees doing it and you're supervising. So I think you absolutely need strategies to maintain the skills. I think you can't beat a cadaver course. I think that's just so realistic, and one of the things that you get out of it is that you can do it under very calm circumstances. The technique that I think is really good to practice is external laryngeal manipulation, but if you wait till the next time you're actually intubating in the ED, you just won't remember to do it under the stress of the circumstances. Whereas if you're in a cadaver lab, you can just do it over and over and over again to see whether it's helpful, and head lift, all the tips and tricks that you might have had, you can practice them under calm circumstances. So I absolutely think, I'm a bit biased in that we run a cadaver course, but I think they're so valuable in terms of upskilling and getting people to maintain their skills and improve with new techniques, particularly hyperangulated video laryngoscopy. I also think that there's the decision-making side of things, which is probably equally important to the technical skills. And so what we do in our centre is we run a monthly airway audit education session for the trainees, and the consultants are invited to come along as well. And then what we do is any case during the previous month that wasn't achieved on the first attempt success, or which was associated with hypoxia or hypotension, we actually try and dissect that case as much as possible and really kind of wring out any learning from the preparation, from the actual laryngoscopy, and just try and distill the educational pearls within that setting so that everyone benefits from the challenging cases that have occurred in the previous month. And we found that very helpful for kind of upskilling people on the decision-making side of things.
Hey, Chris, in those discussions you have at those meetings, is there any common themes that sort of present for the reasons for failed first pass?
Yeah, I think there's lots of, in fact, the themes is the thing we look for. I think I mentioned pre-oxygenation technique. I think if the person holding the mask on the face is not concentrating, you lose that seal, the pre-oxygenation's poor, and you then desaturate a lot more quickly. So that's been an important theme. Other themes that come up commonly are things like conflict around the time of the intubation, and that just impairs the whole team. The performance of the team degrades under those settings. So I think that there are a couple of themes that spring to mind. Yep.
Great stuff, thanks. Now, some of you more eagle-eyed will have noticed that an extra panel member has snuck in here, and I'd like to welcome Paul Baker, who's an anaesthetist from New Zealand. Welcome, Paul. I'm glad you finally made it into our virtual environment. In case you haven't, we've just been talking about access to learning opportunities and things, and we've actually heard that intensivists are almost universally in favour of having airway training mandated upon them, from a survey that David and I did and a few others did a couple of years ago. But your talk, which I found fascinating, was on a different problem, and that's this disconnect between evidence-based practice guidelines and their clinical application. So guidelines come out and they're not adopted, or changes in practice are recommended and those changes are not made, and perhaps people are a bit stuck in their ways. What we're thinking about as part of this session is, do you think that a lack of skills training might be underpinning this reluctance to change? And if clinicians had better access to training, might they be more willing to move with the times and adopt new techniques? What are your thoughts on that, Paul?
Sorry, we're just having a bit of trouble with Paul's sound there. We might go back to you, John, while we just try to troubleshoot that.
Okay, no worries. Yeah, Paul's talk, if you didn't see it, was called Learn, Unlearn, Relearn, which is all about, people with experience having a set of practices that they very much stick to, and they're not willing to kind of make changes in a meaningful way. And they kind of get stuck in a rut, and guidelines come out, and a great example was SATS monitoring from the journey from theatre to the recovery area. It's a guideline. It's been a guideline now for several years, but it still doesn't get done, even where Paul works. And his talk is really about trying to explain some of the reasons why practitioners have for not changing their practice. So, Paul, have we got your audio back now?
Doesn't look like it. Just keep going, Paul. Sorry.
Yes.
We're
I
good.
can see
we
and
got
hear
it.
everything.
We're good now, Paul.
Okay. Sorry. So that you asked whether skill-based training was part of the problem. I think that may be something to practice the way we feel comfortable with, and if that's something we learned when we did a fellowship 20 years ago, regardless of what's coming through in the literature. And I guess that's safe so long as it works well, but it does rather put the brakes on any innovation and improvements in practice.
So how do we break this kind of culture down, Paul? What are the ways, what are the strategies that we can put into place to help experienced clinicians change their practice, move with the times?
Well, that internationally, and I think that was a great innovation that came out of the UK many years ago, but it's having an airway enthusiast in every department of anaesthesia who promotes airway management, promotes the guidelines, does everything they can to keep abreast with improvements, and that's working at grassroots level. because I'm sure there is a disconnect between guidelines where people put a lot of effort into developing things and what's actually happening in the operating theatre. So I think Airway Leads are one solution. It's not the only one. Having regular journal clubs and discussing what's in the literature, going to airway courses, learning skills, all those things help. But I think we have to, as a general rule, as a specialty, we have to keep open-minded and keep up to date. And that's difficult for busy people.
Yeah. So I think Airway Leads is a fantastic idea. ANZCA has appointed Airway Leads in most major hospitals. I know Chris is the Airway Lead for the emergency department. I'm the Airway Lead for my intensive care unit. And I have the honour of also being a co-ANZCA Airway Lead. I think I'm one of the few non-anaesthetists to be an ANZCA Airway Lead. And we have an airway safety group here that is a completely interprofessional meeting that meets regularly to discuss cases and to discuss interventions, for example, checklists and airway alerts and all those kind of things. So embedding experts, embedding people who are going to champion the cause is one. Paul, what are your thoughts on mandatory training? I know that you've written about this in 2016. Is it time for airway management education to be mandatory? You've mentioned a lot of the benefits there, but there's also some problems with mandating training. Is that right?
Well, there are. Made SECO module sort of quasi-mandatory. At least it's one of the modules you have to choose. And I think that's been great. A lot of training to improve that aspect of airway management. But of course, as we all know, there's a lot more to airway management than creating a front of neck airway. And I think airway skills do suffer if we don't practice certain things regularly. And airway courses go some way towards improving that. So yes, I am in favour of making that mandatory, just like anything else. I mean, airway management is one of our core and anything else that's important to us. So, yeah, I support it.
Let me just throw that to the rest of the panel. Nikki?
Yes, I think it's good. I don't think that if you haven't got exposure regularly to things, you're not going to keep your skills up to speed. And I think it's interesting, perhaps this applies more to surgery, but perhaps to this as well, as I'm sure lots of people know who Atul Gawande is, and he had some really interesting ideas about coaching and the idea that we can all be already experts in our field, but we can always be better, and the concept that we can use education as coaching about how we can improve and become even better at the skills that we already are reasonably competent at. And I think that's a nice way to frame it for people who are already working in an area and are consultants, is that they are able to still improve their skills, and that is the approach for that group of people.
Yeah, I like that idea of coaching and mentoring. Chris, mandatory training?
Yeah, so actually ASIM, or the Australian College of Emergency Medicine, does mandate that you do one airway management a year or training on that level, but I think that's too small a number. I'd like to pick up what Nikki said about coaching, and I think we underestimate how much we can almost coach ourselves. So one of the things I recommend for my trainees is actually to try and wring out as much learning as possible from any airway event they're involved in. And so even if you're very experienced, there's always things that you can learn. So I keep a little log on Evernote for the patients I intubate and just make notes on the things that went well, the things that could go better next time, any tips or tricks that came along from the other people in the room. So I think that's a good way to do it, to wring out the learning from every airway event, particularly if you're an occasional intubator.
So we actually do that as a formal process. We call it a debrief, and at the end of every airway list, we actually have a critique of how we did things and what things we could do better. And it's very much an improvement concept that we're trying to think, how can we work better as a team, and how did things go, and were there things that were difficult for anyone, and how could we make that better? And I think if you create an environment where that's normal on a day-to-day basis, then certainly it's possible to extrapolate that into acute airway scenarios as well.
Brewster?
Oh, like I'm a big supporter of mandating it. I think that there's been enough morbidity and mortality out of the operating theatre and airway management. You go back to the NAP4 audit from Tim Cook. That's now 10 years old, and you know you know that an airway disaster is 10 to 20-fold more likely to happen in a patient outside of theatre. So they're the clinicians we need to focus on. With our experiences in Australia with COVID, there's been multiple patients that have had intubations and extubations gone wrong. So where that's led to a terrible outcome. So I think that what we need to do is to focus on that. What the challenge from my perspective for the colleges, if you're going to mandate something, is to make it accessible and give the fellows, so the specialists in Australia and New Zealand, enough variety to tick that box. So if you just mandate one of the 4 or 5 courses that we run, but yourself, Chris Nixon, Paul, myself, there's 2 or 3 others, those courses aren't going to be able to look after the sudden surge of 600 specialists trying to get mandated in 12 months. So you have to give them variety. You've got to allow them either to attend a course or to attend a certain number of intubations in theatre, or and give them 2 or 3 other credentialed activities, and allow them to choose an environment where they do feel more likely to learn and less threatened. So if they don't want to go to a course, but they're happy to go to theatre with a trusted peer anaesthetist to chaperone and supervise and teach, then that might be something they could choose. And with that amount of variety, they should be able to tick off the requirement each year and engage in the program.
I love that. Yeah, what a great idea to have it kind of bespoke and give them some options. Could we get the poll up? Just well, we've sort of everyone on the panel seems to be in favour of mandatory training. Is the poll there?
Yeah, it's coming up now.
Okay, so we've got mostly anaesthetists online, I think. We've got some intensive care physicians, emergency medicines, and paramedics, and then a smattering of others. What are the results for? Overwhelming for all of them. They're not broken down by specialty. No, that's okay.
Does that one person said no, John?
Looks like it.
79 total respondents.
And how many said no, Nick?
One said no out of 78 said yes. 1 said no.
That's pretty resounding.
So this is a shout out to the colleges. I know we've got a group of people watching online who are probably a fairly biased group in that they're interested in airway education. That's why they're here. But resoundingly, we want you to mandate training on us. So bring it on, please, colleges. I just went. Oh, Paul, yes.
I just want to raise one obvious point, that to be an expert airway practitioner, it's knowledge, a good working knowledge of what's in the literature and guidelines, etc. There's skills which you acquire in various ways, and then there's behaviour, and that takes into account human factor things. So, if you're going to run an airway course, you've got to be covering those 3 things. It's not just skills. It's not just a human factor thing.
Yeah, I totally agree. And that is perhaps something that, for non-anaesthetists who come through and get a short introduction to airway management, maybe by a 3 to 6 month theatre run, they might not cover all of those things in enough detail, and that's absolutely right. And if it's not your core specialty and your main focus, then we might find people lacking in one of those 3 key areas, or more than one, when they're practicing as specialists.
So, John, I don't know if you've seen up on the screen there's a question there from Matt Humer asking Chris about whether his cadaver course is made available to other specialties like paramedics, pre-hospital physicians.
Thanks, Nick.
Okay.
Yeah, we don't currently. It was designed initially just for consultant critical care clinicians, and then we introduced a couple of registrar courses. And actually, we're a long way behind because of COVID. We just had to keep putting off the sessions, but I think it's a great idea. So, Matt, maybe we should chat and can come up with a format. But I think it's really good idea. We can definitely do that.
And as you know, John and Brewster mentioned this earlier, at Monash we run a session where the where the intensivists and the emergency physicians come into theatre for allocated sessions. And unlike traditional sessions where these groups come in, where often they get allocated to a list where they'll spend most of their time sitting drawing seagulls on a page, but only get 1 or 2 airway managements. They're chaperoned by an anaesthetist who takes them around, and we just grab, we have an agreement that afternoon the visiting non-anaesthetist will grab as many airway experiences as they can. And generally over the course of the afternoon, they'll get sort of 8 or 10 intubations, and between that we do some debriefing about that, talking around skills, and practice some other skills on mannequins, do front of neck and whatnot. So it's really about exploiting the opportunities, and I'm very big on this idea of collaborating. We need to share the opportunities that different specialties have to practice rather than just wasting them.
Sounds like a great initiative, Nick. Thank you. So shall we throw to the take-homes now? Are we at that stage, Nick? Or
yeah, I think it's time to wrap up. We're out of time, unfortunately. It's been a great discussion.
So thanks very much to the panel for joining us. So the take-home messages from this session: we need clarity around our scope of practice as clinicians. Then we need easy access to regular skills practice, whether that be in courses that are affordable and you can get leave to attend, or organised, collaborative, interprofessional sessions, for example, going to theatres and getting on the list and not just being given an intubation in the morning and sitting watching a laparotomy for 4 hours, but actually going around and getting as many airway interventions under your belt as possible. A great place to start with improving access to airway management is to embed airway champions, and the Airway Leads program is a great example of that. And I know internationally that is taking off. We've already talked about scaffolded learning and how we can break things down to improve people's learning, and incentives to learn, for example, easy access to equipment, the skills lab, tailored courses, and this concept that mandatory training might actually be welcomed by a lot of clinicians. It's established in some professions, but not others, but everyone seems open to it.